sharing with you some interesting cases. The brief history of cardiac pacing. In 1889, the British Medical Journal published an article on the use of electrical pulses applied during asystole. In 1926, Sydney, Australia, they used an electrical socket and plugged in wires into the stillborns to revive them. In 1932, United States, a hand-cranked motor was used to generate electrical pulses. And there was a huge hiatus at that time in this research because the religious groups were opposed to this effort. In 1958, Colombia used a 12-volt car battery to revive a priest. 1958, USA used the first transistorized box. 1971 marked a turning point in the history of pacemakers with the introduction of lithium battery. And 2014, the latest leadless pacemakers have come onto the horizon. What is the mechanism of a pacemaker? It detects the lack of heart's own electrical pulses, and then it stimulates the myocardium with an electrical pulse. And in case where the left and the right chambers are not functioning in synchrony, then it synchronizes the left and the right side of the heart. And that's usually done by ICDs and biventricular pacers. What is the role of a radiologist? Is to report the position of the leads and to judge the integrity of the wires. And portable chest radiographs is not always easy to do because during the cardiac cycle, the wires are in motion and they may be blurred. What are the types of leads? The commonest ones are the transvenous cardiac pacemakers. The commonest approaches are the subclavian or the internal jugular, but the cardiologist may use axillary or cephalic approach, external jugular, or even a femoral approach. Then there are the epicardial leads, which are usually used in a temporary setting. And then there are hybrid pacemakers where there's a combination of both the transvenous and the epicardial leads. The latest on the horizon is the use of subcutaneous leads, and I will talk about those. Now, the basic types of devices include a simple pacemaker and an implantable cardioverter defibrillator, which luckily has a wonderful acronym of ICD. The pacemaking device is usually implanted in the subclavicular location, as shown here, through an incision in the subclavicular region, and the wires are passed through a venous approach, and the leads are introduced into the right atrium or the right ventricle or wherever else needed, and they're anchored to the myocardium. There are two different types of anchoring devices used. They're either the hooking device or they use a helical screw to hook onto the myocardium. The number of leads can be a single chamber where the pacemaker is anchored to the right ventricle. The lead is anchored to the right ventricle. A dual chamber where the pacing leads are anchored at the right atrium or the right ventricle. A triple chamber where they're anchored into the right atrium, right ventricle, and extending into the coronary sinus. What are the different types of devices based on the function? It can be a simple pacemaker, which can be single chamber, dual chamber, or a triple chamber. Or the ICD can have a single shock coil in the right ventricle or a dual shock coil where one is in the brachiocephalic SVC junction and the other is in the right ventricle. Ideal locations for them, the right atrial lead should be hooked into the right atrial appendage, but based on the convenience of the cardiologist, it can be anchored at the lateral wall or the septum or the coronary sinus. And it may not be always possible to judge where these are based on a single portable AP radiograph. The right ventricular lead is ideally anchored at the apex of the right ventricle, but it can also be anchored at the right ventricular outflow tract. The left ventricular lead is fed through the coronary sinus, or in a hybrid situation, they use an epicardial approach. Here's some diagrammatic examples of the various pacing devices. This would be a transvenous single chamber pacemaker. This would be a transvenous dual chamber pacemaker where there is a lead anchored at the right atrium and one in the right ventricle. This is a transvenous triple chamber pacemaker, right ventricle, right atrium, right ventricle, and one extending into the coronary sinus. This is a transvenous single chamber ICD where the shock coil and the tip are in the right ventricle. This is a transvenous dual chamber ICD where one shock coil is at the junction of the SVC and the innominate vein, and the other is in the right ventricle. What is the ideal reporting method for a radiologist? How would you ideally describe so that you can communicate with the cardiologist assessing the patient? This would be a left subclavian transvenous single chamber pacemaker with its tip in the expected region of the right ventricular apex. How would you describe this one ideally in a report? This would be a left subclavian transvenous dual chamber pacemaker with its tip in the expected region of the right atrium and the right ventricular apex. This one you would describe as a right subclavian transvenous dual chamber pacemaker with its tip in the expected region of the right atrium and the right ventricular apex. Left subclavian transvenous dual chamber pacemaker with its tips in the expected region of the right atrium and the right ventricular apex. How would you describe this one? This is a left subclavian transvenous single chamber ICD with its shock coil and tip in the expected region of the right ventricle. This one would be described left subclavian transvenous dual chamber ICD with one shock coil at the left innominate SVC junction and the tip in right atrium, and the second shock coil and tip in the region of the right ventricular apex. How would you describe this? Well, it depends upon which one is in active use. And how do you determine that? The one on the left is not connected. It's not plugged in to the pacemaker. The one on the right is plugged in. So the pacemaker on the right is the active one. And it's important to make that distinction. It may not be always possible because of the angle of the pacemaker with respect to the primary beam of the radiograph. Note that this is a spiral helical anchor used in the ICD right ventricular lead. So how would you describe this? You would say a disconnected left subclavian transvenous dual chamber ICD on the left and active right subclavian transvenous dual chamber ICD with one lead ending in the right atrium and the other with a shock coil and tip in the right ventricular outflow tract. Now, it took me a while to trace the wires to their respective pacing devices and determine which one goes to which. It may not be always possible to do so. This is the latest on the horizon. It has been in use in Europe since 2009. FDA approved it in the United States in 2012. The pulse generator is implanted along the left lateral chest wall, and the subcutaneous electrode is placed in the left parasternal region. It takes 3 times the energy requirement of a traditional pacemaking device, and it's ideally used in people with congenital or structural abnormalities that have, or patients with difficult IV access, or in patients with conducting channel abnormalities. Any questions so far? I suppose it's irrelevant because I can't hear you. So I'm going to proceed to the interesting cases. This is an MR T2-weighted coronal sequence where we could see the abnormal T2 bright signal in the right lower quadrant and a tubular structure shown in the region, which is a thickened appendix, and all the peritoneal fat stranding and edema is indicative of acute appendicitis. This is a patient of fused cervical vertebrae. It's a case of Klippel-Feil syndrome type 3. Klippel-Feil syndrome is a congenital fusion of any 2 or more of the cervical vertebrae. The patients will have a short webbed neck. There's decreased range of motion, and there's a low hairline. The Klippel-Feil syndrome patients are most symptomatic if the patients have fusion at the upper cervical region from C1 to C3. Below C3, they're less symptomatic. Various classifications of Klippel-Feil syndrome exist, but the one most commonly used is by Samartzis et al. Type 1 is a single level of fusion of 2 cervical vertebrae. Type 2 are multiple fusions, but they're non-contiguous. And type 3, in the example I showed you, there are multiple vertebrae fused, and they're all contiguous. Klippel-Feil syndrome occurs as a result of mutation of MEOX1 gene or the GDF6 gene on chromosome 8. It is associated with fetal alcohol syndrome, renal abnormalities, which may include duplicate collecting system, horseshoe kidney, or tubular ectasia. They have associated cardiac anomalies, most commonly septal defects, and limb abnormalities. How would you describe this? There is diffuse, uniform distribution of thin-walled, cystic-appearing lucencies of varying sizes throughout both lungs. This is an example of lymphangioliomyomatosis. Please do not confuse it with honeycombing, and do not call this honeycombing. This is not honeycombing. These are thin-walled, cystic-appearing lucencies. This is honeycombing, where there is architectural distortion. The cysts have thick walls, and you do not see normal architecture in the involved regions. And this invariably describes the condition of idiopathic pulmonary fibrosis, and it starts off usually in the periphery, and it's not uniform like honeycombing is, like lymphangioliomyomatosis is. So honeycombing tends to be predominantly peripheral, lower lobe in distribution with a lot of architectural distortion. Patients with LAM may have associated lipomatous lesions, lymphangiomyomas of the kidneys, and it affects women of childbearing age. It's progressive with an abnormal overgrowth of smooth muscles in the lungs, lymph nodes, and the kidneys. Few of the cases are associated with tuberous sclerosis. Some get angiomyolipomas in the liver, kidneys, and brain, and they manifest with chylothorax. And most common presenting symptom is spontaneous pneumothorax. The treatment is lung transplant. I've put the arrows for you to see the abnormalities. These are wavy, tortuous optic nerves, and they have fluid outlining them on both sides. There is an empty sella and virtually non-visualized venous sinuses of the brain. Idiopathic intracranial hypertension, which was originally called pseudotumor cerebri. Idiopathic intracranial hypertension is caused, it leads to dilated perioptic sheaths, tortuous optic nerves. It leads to empty sella and small caliber or non-visualized transverse and sigmoid dural sinuses. The high pressure is probably caused by a buildup of CSF or poor absorption of CSF, and it affects more commonly women in the ages of 20 to 50 years. And certain medications are known to be associated with idiopathic intracranial hypertension, which is oral contraceptives, tetracycline, and steroids. They usually present with headache, nausea, and vomiting, and the treatment is shunting. So here are the MR images again. Tortuous, wavy optic nerves with perioptic sheath fluid collections, empty sella, and non-visualized dural sinuses. This is a young patient who had minor trauma a month ago and now comes in with severe pain. The only thing we see is marrow edema on the MRI. This is an example of sympathetic reflex dystrophy or complex regional pain syndrome, which originally used to be called Sudex atrophy. In sympathetic reflex dystrophy, the pain is out of proportion to the injury and is progressive. It affects the limbs. Signs and symptoms usually include burning pain, skin sensitivity, sweating and swelling, and redness of the extremity. X-rays usually show osteopenia and soft tissue swelling. Bone scan will show an increased uptake, and MRI will show marrow edema. I have put arrows on this for you to have a look and see what you see. You see some large nodules and some nodular opacities along blood vessels. Here there are some nodularity along blood vessels. Again here. Another patient, smaller nodular foci along blood vessels. Here's a larger nodule associated with beaded appearance of vessels. This is an example of tumor embolism. It is detected in 3 to 26% of autopsy cases. Highest incidence occurs with gastric or colonic adenocarcinomas. Symptoms are of acute hypoxia, dyspnea, chest pain, and cough. There are signs of right heart strain and dilated right ventricle. Death occurs within 4 to 12 weeks. The lung scan demonstrates a checkerboard sign, symmetric diffuse mismatched areas in both lungs, and CT shows the classic beaded vessels that I showed you. This is a middle-aged adult male who has dull chest pain and unilateral lobulated irregular pleural thickening. This is an example of malignant mesothelioma. Its incidence peaked in the 1990s due to the use of asbestos at the shipyards and plumbing industry. 10% of the workers exposed to asbestos get the disease, and the incidence is 3 times higher in patients exposed to asbestos than the normal population. The histology is usually epithelial in majority of the cases. They can be fibrous or sarcomatoid in the rest, and can be mixed in a small minority. The average age of the patient is 40 to 70 years. The patients present with non-pleuritic dull chest pain, and they have dyspnea. This is an adult patient who has chronic shortness of breath. In addition to the diffuse, symmetric, micronodular or reticulonodular opacities in both lungs, you have symmetric, large, irregular, soft tissue opacities in both upper lung zones. This is a case of progressive massive fibrosis of silicosis. And traditionally, the MR appearance is that of T2 dark appearance. This patient had chronic chest pain. There are extrathoracic lenticular-shaped opacities. The one below here shows a low attenuation focus within. This is empyema necessitatis, commonly associated with TB empyema, actinomycosis, or streptococcal or staph infections. And the biggest risk for these patients is the risk of intercostal artery rupture. Thank you for your attention.